So I'd like to welcome everybody to this webinar of the DFOOT International, which is based in Belgium, as you all know. Now, the mission of DFOOT International is one of the largest organizations exclusively for diabetic foot in the world, as you all know. And can you stop the slide share? And yeah, right, fine. So the mission statement of our organization is ending avoidable lower limb amputations due to diabetes globally. Ending avoidable lower limb amputations due to diabetes globally is our mission statement. The new board, consisting of Nicholas Papanis from Greece, Zulfikar Abbas from Tanzania, Dr. Hari Krishnan Nair from Malaysia, and Dr. Hermelinda Pedrosa from Brazil, and Mariam Botros from Canada, took over on June 26th of this year. And after we took over, we have been working very hard. We have been having monthly board meetings in order to include more regional representatives and to include more national representatives from different countries. We realized that there are many countries which are still not a part of DFOOT International. So the first step, what we have done after we took over on June 26th, 2021, is to include more regional council members, to include more national representatives from countries where representation to DFOOT International does not exist at present. Now, the purpose of this particular DFOOT Awareness Week, which was started last year, in fact, I gave the idea to the previous board to start such a program coinciding with the World Diabetes Day. So the purpose of this DFOOT Awareness Week, where one region, we have 7 regions in DFOOT International, like the IDF. And the purpose of this DFOOT Awareness Week is to hear experts from different regions. So first day we had Africa, and we had many experts from Africa, different parts of Africa, sub-Saharan Africa, talking to us. Then we had Central America and South America. We had several experts from those regions. Then we had the NAC, the North American Caribbean region, where Dr. David Armstrong, Lee Rogers, and Simon McConey, they took part. And yesterday we had Europe, where we had some experts from Europe giving their talk. And today we have the MENA region. Tomorrow we have the Western Pacific region. And day after tomorrow, we have the Southeast Asia region, where India, Bangladesh, and Sri Lanka are going to talk. And on the 14th of November, that is Sunday, which is coinciding with the World Diabetes Day, we have a grand finale where Dr. Professor Nicholas Schapper, who's the chair of the IWGDF, is talking, giving a small talk on the IWGDF guidelines. We have Dr. David Armstrong giving a talk on newer technologies in diabetes. We have Dr. Venu Kavarthapu, who's the president of the International Association of Diabetic Foot Surgeons in King's College London, giving a talk on shock of foot. We have a panel discussion among the board members of DFOOT International, which is moderated by Douglas Queen, who's a very good moderator. And then we have another panel discussion by the regional chairs. So this is the program for the week. So as I mentioned, the DFOOT International Week was just to integrate the 7 regions of DFOOT International and hear the experts from all the regions. I'd like to particularly thank Dr. Jamil Labi from Lebanon, whom the board has recently elected as a regional council member for the MENA region. And his appointment has to be sort of ratified by the board, by the General Assembly in June 2022. But the board has elected him as a regional council member. And we thank you, Dr. Jamil Halabi, for organizing this talk, because somebody in each region has to take charge, and you took charge in this region. And we are very happy that the maximum number of registrations happened from this region, 116. I'd like to thank Dr. Miriam Botros, who's our board member and vice president, and she's the CEO of Wounds Canada, for joining us this evening, and her team consisting of Addie North from Wounds Canada, who's also giving support to this webinar. There were some regions where we took charge because we didn't give our secretariat in Belgium. Our secretariat is in Belgium, but for this DFoot International Week, my team in India, Chennai, took up the responsibility for the MENA region and for Southeast Asia and for Europe. And other regions had their own Zoom links. So I would like to thank my IT team, Selva Kumar, Ramya, my secretary, for doing a good job all this week for making it a success. So thank you, Dr. Jamil Halabi, once again. And I would like to welcome all of you to DFoot. And the main purpose is to learn from all of you. It's not that people in the United States or America or Canada already are experts. We want to learn from you. We want others to learn from you. We want you to learn from Africa. We want Africa to learn from you. So that's the whole purpose of this DFoot Awareness Week. And I would like to personally invite all of you to the event program on November 14th, which starts at 1 p.m. GMT, London time. And the link is available, and we can send it to Jamil. It's available on our website, www.d-foot.org. So I would welcome all of you to the grand finale on November 14th. And in the future, you can be rest assured that the board and me will work very hard to develop the MENA region, the Western Pacific region, and all the regions in the world, 7 regions of DFoot, and try to achieve our mission, which is, once again, I'm repeating, is to end avoidable lower limb amputations due to diabetes globally. With this introduction, I now hand over to Dr. Jamil Halabi to take over. Dr. Jamil.
Thank you. Thank you, dear President. I'm happy today to start working actively with DFoot International and moderate this webinar for the MENA region, a region which is full of efforts, full of capacities, and able to shine if it is properly supported. We hope that the weather in India will turn more calm and that you will see happy and sunny days in the coming days. And for today's webinar, for the sake of time, I will just proceed to session number 1. In the first session, we have 6 talks, and the first speaker will be Dr. Sadiq Abdullah from Bahrain. Dr. Sadiq Abdullah, are you hearing me?
Yes, I am.
Okay, please, Dr. Sadiq, we will be more than glad to hear you. And if you want to start sharing your slides.
Yeah, do you see it?
Yes, yes, the floor is yours. You can go on, Dr. Sadiq.
So I have what, 7 minutes or 10 minutes?
7 minutes.
7 minutes. Well, thank you all. An optimistic note, I would like really to congratulate all of you that you've managed to beat the COVID-19, and hope we are ready for COVID-20, if there is anything like that. So nice to see you all in a good shape. So I've been tasked to talk about preventing diabetic foot amputation, a call for action. And quite honestly, the most optimistic experience I would like really to share with you, despite of all the difficulty, is our experience in Bahrain. When I came in 2000, diabetic foot was no-man area, so everybody was sort of doing everything for the diabetic foot and nothing for the diabetic foot. So there was no standardization, and there is no sort of a clear clinical pathway. And I was tasked really to take over the diabetic foot, though I'm a vascular surgeon, and we can see from the background of the faculties that people come from different background, either podiatrist or general surgeon or physician. So we were very much interested in this particular area. And we sort of tried to implement what was a proven fact and evidence. So we use the working group sort of evidence-based facts to apply to our community. So initially, this was our target. So we're targeting the high-risk population. I've worked very, very hard to sort of create the multidisciplinary team. And of course, we try to integrate all that in the overall care of the patient. We are trained, all of us, to deal with diabetic foot, and I'm sure all of you are expert in sort of treating this diabetic foot. What we are not trained at is how to sort of make sort of an overall sort of pathway to prevent the overall amputation rate or reduce amputation rate at a regional or national level. This is totally completely different task. So you can be fantastic in your institute, but your effort will be only that small effort. But at a national or regional level, it's totally different task. It depends on politics and business and so many other things that we are not very well trained to do. So as I said, we've been sort of following the working group evidence in tackling high-risk patients for vascular and neuropathic. This is our hospital, which is 1,200 beds. Hospital is a huge place with sort of multiple specialties. So in the diabetic side or in the vascular side, we were sort of working very hard to target the high-risk group patients. So we had our clinical pathway from the health center and from the GPs and from everybody, and we sort of been sort of reaching out for these physicians and doctors and nurses to refer these high-risk patients. Also, we created our own team in the hospital, which was multidisciplinary team of vascular surgeon, orthopedic, plastic, and so on. And of course, we were sort of adhering to follow up these patients. It was a small area in a corner of a hospital. We created our diabetic foot, but was surrounded by all the other facility. So if you see, you can see, you see my cursors here. So this is sort of our diabetic foot. It's very small, but in front of it, we have a row of consultation room. Next to it, we have the vascular lab, the angio, and we have small minor theater for debridement and drainage. So this is the actual picture of the place, which was open in 2008. Patients were referred from different health centers, and they just come up with referral note. We don't take appointments. Any patient who need to come to this clinic, they can just be referred by their physician or even by their nurses to come to us. So we were removing all the barriers for these patients. So because tissue is, or time is tissue here. All these patients would have the initial assessment that everybody is aware of. But what we sort of specialize ourselves into is that we created this sort of eagerness to treat these patients when they first arrive almost instantly. So those who's coming with severe infection, deal with it instantly. Don't wait for next day or anything if they can survive the surgery. And revascularization is very much a procedure that we do instantly. If the patient, even in the evening, we would go and interfere and do for them bypasses, for example. And from there, we sort of expanded toward the more complicated cases. We try to adopt all the new technology like the VAC and all this stuff. It wasn't easy, but you know, you need really to work up your logistics and get whatever you can in this, because this is overall, it is a very neglected specialty in some part of the world. So this was the pictures when we come, sort of all these ugly looking and devastating cases. And with that little effort in the first years, the picture has changed completely. So we don't see anymore these pictures in our hospital or in our clinic. And we see more and more patients coming with sort of initial infection and early intervention and early treatment. Angiogram and angioplasties and bypasses were sort of hands-on. When they come, we just deal with them as the patient coming with ischemic heart attack. So we don't really wait too long in these patients if they are coming with acute ischemia. And of course, with further sort of experience, we've managed really to integrate with our plastic colleagues. So all sorts of flabs, complicated flabs, and skin grafts and everything were sort of being handled together with our plastic team. Charcot joint also, we used to see all these devastating picture that I am amazed now that we are seeing less and less of such images, and we are seeing patients in the really very early stages of the Charcot. We built our vascular team, and we make a training and education an integrated part of our unit. So we have all our training and education in the same place to create the atmosphere of sort of being cozy and being everybody taught. So the junior physician, the nurses, the doctor, they all receive the same education. So there is no leader here. Everybody is leader, everybody is a follower. So this is sort of the atmosphere that has been created. So it was sort of very cozy and very nice team to work with. And as I said, we've always conduct our seminars and everything in-house. We never go to these fancy hotels to do our events. It is all in-house. And we involve our plastic, orthopedic, and everybody would come to these sessions. And continuous education and training, I think it's very important. Community being part of this, and community been taking their responsibility, and we had a very, very good support from our community. So before the diabetic foot clinic and after the diabetic foot clinic, the figures has changed dramatically, and we managed really to reduce amputation rate. This was sort of an old statistic. We managed to reduce it 22% in the first year in major amputation. And we managed to reduce admission to the hospital because of diabetic foot 45%. There is always the unavoidable. I have just 2 slides. There is always the unavoidable cases, like this situation where patient having kidney transplant, and you have to decide whether to save the leg or save the kidney. But multidisciplinary teams are not a new thing. It is an old idea, but knowing how to deal with it. And from so many studies like the Eurodial, we understand that this is not easy, even in sort of European and North American countries. My call for you today, ladies and gentlemen, is this concept. Social media has become a very important thing in our part. I enjoy the sort of diabetic foot day or week, but I think we need to be communicating with each other in much more real life. having an app, this is my suggestion, is to have some sort of registry through one of, like creating a platform for the different diabetic foot center in the region and for the doctors as well, where they can register their patients on a daily basis.
Dr. Sadeh, I think we will take this as an action plan in the end of session 2 at during the discussion how to implement. So thank you very much for your expose, for your presentation, and I hope you will stay with us and give us what you wanted to say as implementation at the end of session 2 during the discussion. Thank you, Dr. Sadeh. Now we move to the second presentation for today with Dr. Salma Khuraybat from Kuwait City. Dr. Salma, are you with us? Dr. Salma? Dr. Salma, we can see your screen. Are you ready to comment? Dr. Salma? Okay, for the sake of time, we will move to the third speech, and when Dr. Salma becomes ready, we will give her the floor. So Dr. Bashir Tarazi from Palestine. Dr. Bashir?
Yes.
Yes, can you please share your slides and start?
Yes, thank you very much, Dr. Jamil. Thanks, everybody. It's really nice meeting you, and this is the occasion to celebrate and for diabetic foot awareness. And of course, this is really, my talk will be actually directed to the primary healthcare physicians where to implement some sort of examination. So going to the facts that every 5 seconds, one person develops diabetes, and this is really now known to everybody. Every 10 seconds, one person dies of diabetes. Every 1 to 2 seconds, someone develops foot ulcer. Every 20 seconds, a limb is lost due to diabetes. So diabetes, as declared by the UN, resolution 6125, where diabetes in 2000, diabetes is a chronic, debilitating, and costly disease associated with severe complications, which poses severe risk for families, member states, and the entire world. So the case findings where
Dr. Tarazi, we cannot see your screen, your slides. Can you share the screen?
Okay, just a moment.
Hello?
If you please.
Hello?
Well,
you can hear me? Oh, sorry.
Dr.
Salma, we started with another presentation, and
okay,
we'll
let's Salma, go, and I will really go
please,
back.
Please continue, Dr. Bashir. Can you share your slide, or you are not ready?
I'm really just a moment. Share.
Yes. Okay, Dr. Bashir.
Okay, thank you very much.
Yes.
I think that we started with this. You did not see my slides. That's why. Okay. So this is really directed to the primary healthcare physicians, where we have to implement some sort of implementation to start really examining every patient. And so we have to go for the facts that every 5 seconds, one person develops diabetes. Every 10 seconds, one person dies of diabetes. 1 to 2 seconds, someone develops foot ulcer, and 20 seconds, a limb is lost due to diabetes. So diabetes is a chronic, debilitating, and costly disease associated with severe complications, with poses severe risk of families, member states of the entire world. This is really the UN resolution 2000 in the occasion of Diabetes Day. So the case findings, what we can see that the cellulitic infection, it's really common, we see it. Ulcer formation, the autonomic nerve damage with the dry skin and lacerations, and the sensory nerve damage, and with the painless nature of diabetic foot disease, as you see in this is really very terrible that a patient cannot really feel and got really ulceration and complication. And the motor nerve damage, as you see. And of course, the Charcot neuroarthropathy with the claw tone, the deformity, and and the Charcot arthropathy, which is really a major complication. And the gangrenous and going to amputation. Actually, can we prevent amputation? This is really the question, and this is why we are here. So the question here, what is the biggest obstacle to making foot exam as a routine part of office visits for patients with diabetes? So is it lack of time and lack of specialized equipment like vibration perception threshold or monofilament, needs to focus on urgent clinical concern? There are no obstacles, ladies and gentlemen. So this is really, and it is a routine part of these visits and will take 3 minutes. Let's go to the 3-minute examination were adopted by the ADA, task force, and who is the 2 persons that we were working, that Professor Andrew Boulton and Professor David Armstrong. This is really practical, and I like really to present this because I'm in the field and I can really train the trainers really how to examine the patient. Now, 1 minute, 3 minutes, the first minute is what to ask. Does the patient have a history of previous leg, foot ulcer, or lower limb amputation surgery? Prior angioplasty, stent, or leg bypass surgery, foot wound requiring more than 3 weeks to heal, smoking or nicotine use, diabetes, is it controlled, not controlled? This is really very important to ask and see the situation or the condition of the patient. Does the patient have burning or tingling in legs or feet, leg or foot pain with activity or at rest, change in skin color and skin lesions, loss of lower extremity sensation? Has the patient established regular podiatric care? All these questions does not take any time, just 1 minute. What to look for, it's 1 minute also. The dermatological exam, actually, this serves as a barometer for early intervention and often results in limb-saving referral to a specialist. Does the patient have discolored, ingrowing, or elongating nails? Are there signs of fungal infection? Does the patient have discolored and hypertrophic skin lesions, calluses, or cones? Does the patient have open wounds or fissures? Does the patient have an interdigital maceration? The neurological exam actually is very important. And the Ipswich here touch test is really a fantastic and really a rapid examination and reliable. It really comparing with the tuning fork and the monofilament. So we have it, and we can touch 1 to 2 seconds, really, 1 to 2 toes, 3 toes, and say yes or no if he feels your finger. So musculoskeletal exam. Does the patient have full range of motion, the mobility of the joints, of course? Does the patient have obvious deformities? And this is really where he is reliable really to have ulcers or recurrent ulcers. Is the midfoot hot, red, or inflamed? This is very important also. Is the hair growth on the foot dorsum, which shows really the circulation in the foot? And are the dorsal pedis and posterior tibial pulses palpable? What to teach? This is really where maybe Dr. Salma is going to do, but visually examine the feet. This is very important. Education regarding shoes, what he is wearing, and overall, the risk management recommends smoking cessation and recommend appropriate glycemic control. Glycemic control, it should be really tight control. Otherwise, we have trouble. Now, the part of the specialist actually, and we have really 4 categories as the ADA risk categories, is the very low risk and the low category and the moderate and the high. Urgent, active, I'll go through it. Urgent pathology, active pathology, open, this is indication, open wound or ulcerative area with or without signs of infection, new neuropathic pain or pain at rest, signs of active Charcot neuroarthropathy, red, hot, swollen MENA, should enter immediate referral to consultant. This is really the fast track. We are really in the Abu Dhabi where we have used to, with Zahid and with William and everybody were present there, that we have come to a conclusion that it should not be a clinical inertia. It should be really a quick referral, rapid referral in order to save the leg. So the high ADA risk, a presence of diabetes with previous history of ulcer, Charcot, neuroarthropathy, lower extremity amputation, immediate or next available outpatient referral every 1 to 2 months. This is really, so the moderate is peripheral artery disease or a low protective sensation. This is very important, that it should be really referred within 1 to 3 weeks. We don't wait. Not already receiving regular care, every 2 to 3 months follow up. And the low category, where the long-standing, non-changing deformity, it's stable, nothing really to do, referral within 1 month, every 4 to 6 months follow up. And the very low, of course, nothing towards it, just observation. And this is really referral within 1 to 3 months annually at minimum. This is. So my conclusion here is the CPR for feet is to check, protect, refer. This is really very important and without any delay. And thank you for listening.
Thank you very much, Dr. Bashir, for a very interesting talk. It's a real 3 minutes exam. And now we move to Dr. Salma Khuraibat, who will give us also another interesting talk, also about physical exam, but it's about mainly patient education, how to do self-foot examination. Dr. Salma from Kuwait, the floor is yours, and we are starting to share your slides. Please go on.
Yeah. Thank you very much, and good evening, everybody. And I don't know, good morning to some of you, and good night for some of you as well. I'll just go for my talk here. Just, Miriam, if you're sharing my slides, there is a audio slide in the end. Just I might need a few minutes so you'll be able to hear it. Okay, so the talk today, my talk today is about the self-foot examination. Is it teaching the patient? Would it really help in improving the outcome of the foot care and reducing the complications of diabetic foot as ulceration and amputation? Next slide, please.
Adi?
Arrow, you need just to press the arrow, yeah. So there's a study here, a systemic review, actually, a study done by Richard Godal and colleagues, and reviewed all the literature mentioned studies from 64 till 2019, the impact of patient foot care education on self-efficacy and self-care behavior. Does it really improve the outcome of the diabetic foot care, self-care of patient? And if you may see here on the side here, this is actually a patient whom I treat during the COVID era, and it would just by teaching the patient how to do foot care over the WhatsApp and giving instruction, and this is the difference between the top picture and the second picture sessions. So it could be a good also a way of teaching the patient how to look after their wounds. Next slide, please. One more click. So the systemic review, they found around 13 randomized controlled trials, and the total of around 4,000 individuals, they were subject to self-foot examination. But in general, there are many bias and those randomized controlled trials, because there were different subjects of education, and also not many items were mentioned about what is exactly was mentioned to the patient. So 8 out of the 11 studies identified significantly better foot self-care and behavior score in individuals in randomized control studies compared to the control ones. But in general, the studies assessing the secondary endpoints, quality of life of ulceration and amputation, was not really significant. So does really foot examination really improve the unwanted complication, which is amputation and the quality of life? Next. And Ronell et al. Showed that the benefit of individualized education did really better. So if you do face-to-face, one-to-one education would be helpful, and also compare that doing a persistent education would really improve the patient awareness regarding their food. So the faster they find abnormalities in their food, it would really improve their the complications which could happen in diabetic patients. But the issue here, does really this the patient, will they really be attached to the education and the awareness you would do it? And what kind of education would you and awareness would you give it to the patient? Is it just oral or verbal? And they found that doing it as an interactive education would do much better rather than videos or just handwritten, because most of those patients, they have visual problems, and some of them, they have some mental issues or comorbidities. So doing not only one-to-one education, but also doing it as an interactive, keep the patient or whom taking care of the patient is really aware of the importance of food care. And also the education is not only going to the patient, as you might see in the top, where I was sitting with standing, actually I was standing and talking to the patient and trying to evaluate, and I will tell you the story of the patient in the end of the talk. Next slide, please. And there's another study by Kigret. Individuals receiving hands-on diabetic food care education as well as instructional videos, they do much better, as I mentioned earlier, they do much better comparing to those only, you just keep rehearsing it without emphasizing that the patient does really grasp all the information and the important points to be given. And this is one of my patients was participating in an event distributing the about food care in a shopping mall, where he just trying to distribute the information about the importance of food care and being an active member in education. Next slide, please. And the systemic review, in general, from 1946, or most of the actual studies, or we can rely on from 2012 to 2018, the food education program does improve the self-food care behavior in elderly or in older patients with diabetes. It did mention this, but the bias here goes again. What is the system of education, and for how long, and what messages would you give, how frequent, and is it going on forever, or is it just few sessions and then you forget about it? Next slide, please.
Dr. Salma, 1 more minute, please.
Okay, I'll do that in a quick. One more slide. Yeah. So food care education, improve the outcome. Yeah, it's okay. Go on. One more slide. One more slide, please. So never stop, educate the patient and make them aware about their problem. One more slide. It's very important you shake hands with the patient feet, examine the feet. You do it and let the patient do it. And you just less than a minute talk of a patient. Anything you can hear?
No.
I'll just try to do it from my side. Yeah.
وآخرا أنصح كل مريض مصاب بداء السكري أن لا يهمل العلاج والنصائح التي تقدم إليه من قبل الدكتور الدكتور المختص على الحالة أولا بأول حتى يتجنب أي مضاعفات تحدث له خلال هذه الفترة. متمنيا للجميع دوام الصحة والعافية. أخوكم خالد حسين الفلفل.
That's a talk. Just I have one slide to mention, if you don't mind. Just go.
Yes. Go on, Dr. Salma.
So that was the patient testimony, and he was mentioning here, healing is hard, but staying wounded is harder. So just please look after your patient, try to heal their wounds, and never keep them wounded forever. Last slide, and thank you very much.
Thank you, Dr. Salma.
You're welcome. Thank you.
Okay, so now it will be my turn. I will be talking about the role of surgery and about the role of the surgeon's knife in the control of specifically diabetic foot infection. We cannot talk about surgery without having a small anatomic point of view. If we take one feet, we will find many bones. So both feet contain 52 bones. On the other hand, the entire human body is made of around 200 bones. So the 2 feet makes up 1/4 of the entire human body. If we want to add to the number of the bones, the number of joints, we have 33 joints and more than 100 tendons and muscles. And if we add to that the macro and micro angiopathy causing poor antibiotic concentration in bones and tissue, now this will help us to understand how easy is it for the infection to spread. And on the other hand, how difficult will it be to control this infection by using or relying only on antibiotics. When we say in each foot there are 33 joints, this means 66 cartilaginous articular surface, and cartilages are avascular and they are an easy victim for bacteria. Tendons are also avascular and they act as fast-track highways for bacteria, and this will facilitate the spread of infection not only inside the foot, but also their ascension into the leg. One phenomenal anatomic thing is the absence of interosseous membranes. Usually between tibia and fibula, we have an interosseous membrane, the same also between radius and ulna, but in the foot, we don't have interosseous membranes. None of the 4 anatomic layers that constitute the plantar aspect of the foot obliterates the way from the dorsum, from the plantar to the dorsum aspect of the foot. Conclusion, any plantar infection can spread to the dorsum of the foot and cause a severe damage and even sometimes a necrotizing fasciitis. Here you can see the open communication between plantar and dorsal foot. The diabetic foot surgeon is a man with a mission. The mission is to avoid preventable amputations. Second is to save limbs to preserve patients' autonomy. And third is saving lives when life is under threat. Diabetic foot salvage is not a one-man show. It's rather a teamwork among multiple specialties. So how to save? It is to rely on the knife in the operating theater, and the surgeon must work meticulously to eradicate all infected tissues and never ending the surgery quickly. So if no one can do it, I must do it. And pre-operatively, we have to plan to map the infection, to do the smart moves, look for swelling, erythema, blisters, etc., request the appropriate imaging modalities, and then go to the operating theater. Check the vascular imaging by myself not only read the report, talk to the vascular surgeon, communicate, not only read the notes, and try to get revascularization, stent, or bypass done before debridement or minor amputation, unless there is a massive sepsis. The principles of diabetic foot surgery in infection is to avoid excessive cauterization, to probe and widely unroof the tract, brush, irrigate, because the solution to pollution is dilution. And sometimes I even attach a Medicath or irrigation catheter in the wound bed for 24 or 48 hours post-operatively. So in diabetic foot infection, we have a triad: surgery on one hand, antibiotics, and meticulous wound care. The role of surgeon is to secure cultures at the end of surgery from the final wound bed before starting antibiotics, start high antibiotics and de-escalate according to antibiogram, of course, coordinating with an infectious disease specialist. In the special case of a plantar ulcer or nail prick followed by erythema in the dorsum of the foot or ascending to the anterior aspect of the leg, think of necrotizing fasciitis of the extensor tendons. Look for subcutaneous emphysema crepitations. Request a CT scan, not an MRI, to look for gas. And start immediately hyperbaric oxygen. Basic surgical principles in diabetic foot infection. First, wide local excision, as if I am dealing with a tumor, not only to excise the necrotic area. Aggressive debridement is the name of the name, and stop only when we reach bleeding, bleeding skin, bleeding subcutaneous tissue, bleeding muscle, and even bleeding bone, and never before bleeding. Don't think about reconstruction at this moment. So here I am excising soft tissues, but when I reach the bone, if the bone is devitalized and if there's a purulent bone, we should not hesitate to remove the devitalized tissue of the bone until we reach bleeding bone. In cavitary wound surgery, the rule is to have a small wound bed and a wider wound opening so that everything will be evacuated to the outside. Never accept undermining at both wound borders. The way I like to do diabetic foot infection, especially in the plantar, is not to go for a classic incision and drainage surgery. Rather, I go to what I call a transfacial longitudinal excisional incision. Map the infection, identify the entry point, and then not incise, rather excise on each bleeding tissues. Not worrying how this wound will heal. It will end up by healing, and by healing nicely. This is another transfacial longitudinal excisional incision, and you can see the progression until we have a full healing. This is a case of osteomyelitis of the first metatarsal, also excisional incision that ends up with good healing. Now I will talk about necrotizing fasciitis of the dorsum of the foot, aggressive debridement till the tendons, even the tendon sheath is excised, then followed by negative pressure, skin grafting, and an excellent result. Another case of plantar foot infection treated by the excisional incision, followed by negative pressure with good granulation tissue, then Integra artificial skin graft, xenograft. Why? Because I want something thick under the first metatarsophalangeal joint to avoid later on ulceration. Then finally, a skin graft with an excellent result for the patient. This is an 8-month-old boy in the pediatric ICU. Due to IV pricks in the foot, he developed necrotizing fasciitis that extended to the mid-leg. The orthopedic surgeon wanted to amputate, then I was consulted and I did an aggressive debridement followed by negative pressure, and then I skin grafted the boy and he did well. In real life, there is a mix. There is no infection alone, no ischemia alone. There is a mix of all together. How to guess? This is the wound care property where we have to meet the wound and read it. Meet the wound as if it is a real person. And the wound has many things to tell me. So connect with the eyes, look at the gauze, check what is missing, what is lacking in the wound, and go for serial debridements, serial cultures also if the wound stops progressing. And for the antibiotics, start high and then de-escalate, because in diabetic foot infections, time is tissues. Many amputations are due to either a delay in empiric antibiotic treatment or to a bad initial choice. What are the specific obstacles in diabetic foot infection? Anatomic considerations like tendons, cartilages, patient factors like HbA1c, anemia, uremia, non-compliance, caregivers related surgeon or infectious disease who give up, especially under third-party pressure. The strategy to win is adequate surgery, adequate tissue culture at the end of surgery, adequate initial empiric antibiotic, serial surgical debridement, teamwork, insulinize the patient even if the glycemia is fine, vasodilate with nitric oxide or pulsed electromagnetic field, and treat the whole patient, not a hole in the patient. Don't give up quickly. There is always a way, and thank you for your attention. Now we move to the next speaker, and I hope that Dr. Khalid Idris is here with us. Dr. Khalid?
Yes, I'm here.
Dr. Khalid Idris from KSA. We are very happy that you joined, and you will give us something very interesting today that we rarely talk about, the role of maggot therapy in preventing amputations. Dr. Khalid, you can start sharing your slide. The floor is yours.
All right, thank you so much. Let me first figure out how to share my slide. So if I'm here, لا معلش غشيم شوية بتعلم. It's all right. So share screen.
Share screen, yes, Dr. Khalid.
Got it. It's okay. I'm learning.
Okay.
All right.
Dr. Khalid, can you go to full screen, to the full screen mode?
Can you see it now?
Yes, of course.
All right.
Thank you. Go on, Dr. Khalid.
It's a bit frustrating because when Dr. Halabi called me, I was late. I was in the ICU telling a patient and his family that we need to amputate below the knee. That is very frustrating for somebody like all of us, which means that I feel like I failed. I failed to really heal this patient. Of course, there are many reasons. I'm not going to get into it. So maybe if we had flies around, we would have healed this patient. So let's talk about Lucilia sericata, which is the blowfly maggot therapy. I'm going to go through history, through the fly itself, therapeutic indications, mode of action, and some studies. This has been going on since ancient times. Maybe in Egypt, the Mayans in South and Central America have been doing this. The first mention in the US was in 1928, but in Europe it was before that. And as we will see it now, Baron Larry in 1766, an army doctor and a personal physician to Napoleon, he noticed that the soldiers who had cuts and big wounds who were left in the field and had maggots on them healed much better without infection than the soldiers that were taken to the tents and were treated. And that was done during the Egyptian campaign. So back to Egypt again. And he was trying to convince the soldiers, don't remove the flies, keep the flies, it's good for you. Dr. William Baer, an orthopedic surgeon, then took that and started writing papers about it. I'm not going to go into the history too much for the time. This is called the larvae cage. Of course, now we don't do that. We don't do it this way. We do, when we say we do, I am not doing it in Jeddah, just for everybody to know. I did it in my residency when I was in Miami. And of course, I just came back from the States as well. The way how it is done now is you put hydrocolloid dressing around the wound, and then there's a special mesh. because if you don't put a cage, they will run out. This is the natural cycle. A fly lays eggs. When a fly comes to you, it's not like a mosquito. A mosquito is looking for blood. A fly is looking for something dead to leave its eggs so that when the eggs hatch, they find something to feed on. These are actually the maggots when they hatch out of the egg, very, very tiny and small. They're highly mobile, so they will go everywhere, and they're robust. So the labs in the US and in Europe, they send it in DHL or FedEx. They will survive. They're very hardly. I mean, imagine they live under the soil when they eat, and they eat all sorts of stuff. So of course, now I'm going to get back to the word eat, because they don't actually eat. So this is how big it gets once it finishes feeding. Starts really tiny, it grows to about 10-fold. So what are the indications? All kinds of ulcers, any kind of necrotic ulcer, whether it's diabetic or it's Dr. Halaby's necrotizing fasciitis, these guys would do a great job on them. What's the mode of action? It's fast debridement, antimicrobial effect. They promote granulation actually, and one that I added, it's my addition to it, they induce offloading, because just if you think that there are maggots under your foot, you're not going to put that foot on the floor. So it's a side effect that is really good for us. So you have many different kinds of debridements, and what we're adding to the new kind of, the old new kind of debridement now is biological debridement by these living organisms. They're biological microsurgeons. So coming back to eat, they don't eat. They do something called extracorporeal digestion. So they don't have big teeth. People imagine them eating the necrotic tissues. They don't. They excrete their saliva, which has very strong proteolytic enzymes and antimicrobial effects. And then they sip it, just like you sip a Coca-Cola or a drink. Then they ingest it. Whatever their enzymes don't kill outside will be killed in their stomach by the enzymes inside the stomach. So viruses, bacteria, any kind of infection will get destroyed by these critters, because just imagine where they live and what they eat. So they will destroy everything. All my presentations have my own pictures, except this presentation. I do not have any of my own. So this is from the literature and from the net. I usually like to point that out. This is a very big leg ulcer. This is after debridement. Let's look into some studies. Maggot secretions inhibit the growth of bacteria in vitro. This study from 1957, that's how old people have been looking at it. And they said it kills E. coli and kills streptococcus. Let's look into an electron microscope. This is actually inside the gut of the maggot itself. You can see in the picture on the right how the viruses and bacteria get destroyed. This is, remember, when we have bacterial resistance to antibiotics, these guys come into play. They fell out of favor when antibiotics were developed and penicillin came into play. Whereas before that, you had no choice. If you have a bad infection, you had to use maggots. So does the maggot secretion promote the proliferation of human cells? Does it promote granulation? There are many studies, believe it or not, that show that yes, they do promote granulation. And this one study shows that in the control, the interleukin-6 has increased, and interleukin-6 secretion in the secretions have also increased. And interleukin-6 will promote granulation in its way. So there's another study that shows the actual crawling, the massaging of the wound bed actually promotes some granulation tissues. In summary, they do fast debridement, antimicrobial effect, promote granulation, and offloading. These are my very famous shoes. I have had these shoes for many years. They're always dirty. I write on them full of viruses, fungus, and infection, so nobody will take them. But now very soon, I'm gonna say full of maggots as well. This is another study, 2002. Let me see the time. I have very little left. I'm gonna go to a study, the latest study that I found. By the way, every study shows that maggot therapy is very effective and has virtually no side effects whatsoever. I wanna go to this last study here. This is the newest study I could find from Malaysia. Apparently this is big now. And they showed in one study that it actually prevented amputation in 11 cases. And in another patient population, 25 patients were prevented from having an amputation. There are a lot of studies in the literature. And what we're talking about preventing amputation is we're going to do debridement better than Dr. Khalid Idris. My time is finished. And better than, believe it or not, Dr. Halabi himself, because we work with a knife. They work on microscopic and microscopic level. These are the labs where they're produced, they're cultured, so they come to you sterile. This is just a joke. This is when I was in California 2 months ago. This is on the left side is Dr. Ronald Sherman. He's the father of maggot therapy in the world. Most of the studies you will see that it's by Sherman. And hopefully we are going to open the labs soon in Jeddah within the next year and a half. And I'll be more than happy to send you some maggots whenever you need it. Thank you so much.
Thank you. Thank you very much, Dr. Khalid, for a very interesting and informative talk. I think in our region of the world, we miss it. Sometimes regulations, local regulation in the countries prevent using or selling maggots because it's considered as an animal or a human being. So I don't know if the regulation will keep stopping us. For example, in Lebanon, we cannot sell maggots or buy maggots or have them, but it's very interesting. And I think that you are very right. And one of the things we can plan for is to have maggot therapy in the MENA region. Now we will move to the last speaker in session one. Last but not least, of course, our dear friend, Dr. Muhammad Al-Makki from Sudan. Dr. Makki? Dr. Makki? Yes, Dr. Makki from Sudan, you can start sharing. Yes, we are seeing your slides.
Can you hear me?
Yes, yes, Dr. Makki, we hear you. The floor is yours.
Okay, thank you. I think this picture just probably demonstrates what we all been talking about to avoid not only just amputation, but even amputation and infected stomach, which is a really disaster for a patient who already had a wound and now ending with another wound. Next slide. Well, I think my advice to the patient, they should assume that they have got loss of sensations. As you can see in this picture, he is wearing this slipper and he's tying it because of the sensations. He's going to lose it. I think my advice is that you shouldn't have any sort of slipper. It has to be covering all the foot. And there must be no thing between the toes because this is usually a very common cause of interdigital ulcerations. Next slide. I think this is the area where patients should have a look at their feet. And if you have this sort of keratosis or cracks, I think certain lubricants has to be used. And my advice to the patient not to use it between the toes because that might cause some sort of maceration. And this is interdigital ulceration. I think fungal infection is quite a common thing and it's usually being missed. And this is my advice that every day, probably with the prayer, when you are really doing a wudu, probably, you might just inspect your feet, see between the toes, make them dry. Try not to put any ointment between the toes. And as you can see in the lower picture here, this sort of keratosis on the dorsum, and I think this is probably due to the sort of pressure from the footwear. And I'm going to talk about the footwear later on. look at this. I mean, you never imagine. And I think my advice usually to the physicians, the family physicians, if you have got a diabetic, please just have a look at the food, please. And you are going to discover a lot of things. And my advice to them, I mean, I know the generic thing for any diabetic to avoid complication are three. First, I ask him whether he has got a hemoglobin A1C below 7%. Number two, his lipid profile. And number three is to avoid any sort of smoking. Yeah. Look at this. I mean, these cracks, unbelievable. I mean, this sort of patients. And when you have got a pile keratosis in one area, then you have to shave it with a knife. I think ointment early and probably shaving later on. Deformities. I think these toes, as you can see, being curving down. I think there is a way that you can put some sort of cotton below so that you straighten them. And I think here's the footwear and the podiatrists. We don't have podiatrists definitely, but we have actually this foot clinic where we have both the nurse and the shoemaker so that they will be doing the right thing for every shoe. And please, if you are wearing the shoe for the first time, you are going to usually buy or purchase a tight shoe because you have got a lot of sensations. So please, if you take a shoe, wear it, make measurement, but don't wear it more than probably 15 minutes, then half an hour, and have a look at your foot to see if there is any cracks or maceration or probably blisters. This is the same thing. I mean, this is the patient, this is anhydrosis happening from autonomic neuropathy, and it's usually coupled with the sensory loss. So this patient needs lubricant, and this is actually the head of the first metatarsal. I mean, this sort of deformity is actually inviting for an ulceration at this side. And this is usually has to be really well worked with the foot care and the shoes maker so that they will reduce the pressure. If you have the mat, you can even measure the pressure. If there is an ulcer here, then you prescribe a shoe, let the patient again stand on the mat, and you can find that the pressure at this side being reduced. And this is what makes healing. It's not antibiotics when you have both this sort of superficial or ulcers. If you have a swelling in your foot, sometimes, yes, cellulitis, but don't forget, and this might be a Charcot, an early Charcot. And walking on this foot, so you have to go to a diabetic foot. Somebody is not like any physician. I mean, he has to diagnose Charcot. Many of these patients are being diagnosed at infection, osteomyelitis, given antibiotics, they are working on it. And if you work on it, they are going to have a lot of fractures, stress fractures. And at this stage, you might even lose your joint. So please, if you have got a swelling, might be warm, the differential diagnosis would be, is it really an osteomyelitis or is it a Charcot? I think you can do the whole study, the CRP, the X-ray, and the MRI probably that is going to make an early diagnosis of Charcot and avoid all the late complications. The second thing is that if you notice that one of your, look at this big toe here, if the hallux got larger, then usually these patients do an X-ray will find an evidence of osteomyelitis. Be very careful about if the one of the toes is getting bigger than the other one. And if you press it, sometimes you might find a very small hole. That is probably a site of infection, you can prove it. But those patients, if you don't have any openings, then you might give them trial of antibiotics. Usually they need antibiotics for a long time, 6 weeks, 8 weeks sometimes. But ideally, if you can have a culture and sensitivity, that will be okay. That means if you have got an opening, getting some material from inside by a probe, then you will have the right antibiotic for that. And this is actually the shoe place. We have this factory, and we have the foot care around. I think the combination between the two is a very important addition to the patients. You have to have this actually first aid. And usually tell them when you are cutting your nails, please do this, not yourself, but in case that you are doing the nail cutting, you have to have some antiseptic so that you can just, be some very small pores that might cause infection. So perhaps nail cutting should be done in a proper place or otherwise has to be really guarded. And this is a very common thing, blisters. I think this can happen in our situation here because of the hot weather or from the tight shoes. And especially if you are walking barefooted probably in a floor, you might get actually a blister of the whole plantar. The treatment is very simple, I think. We usually try, open it, clean it, you'll find a very small flat ulcers, and this is going to heal just within 2 or 3 weeks. Unfortunately, those sort of things, marat, they aspirate it, or they prick it with a sword or with a nail or whatever it is, and that is probably the start of the cellulitis and infection. So a blister has to be really managed in a foot care clinic. And I repeat, somebody, you don't go everywhere. You have to go to somebody who is actually doing the diabetic foot. You learn every day from the diabetic foot, whatever you read. But the more practice you have, the more information you have, the better you are. And a lot of these patients, I ask my physician, please, if you have got something in the foot, please refer them, because usually they tend to prescribe antibiotics for anything. And this is actually our most difficult situation of vascular. We don't have actually probably that angioplasty is just limited to very private places. And really, this is really our weak points here is to have a vascular setup. Thank you very much, Dr. Jamil.
Thank you. Thank you, Dr. Makki, for being on time. It was a very informative talk, and I like the idea of the shoemaker in the center. I think one of the problems that we are facing in the MENA region is the lack of podiatrists. In session 2, we have a bright podiatrist in Lebanon, Dr. William, who will talk to us. And I think in the discussion, we should raise the issue of lack of podiatrists in the region. Thank you. And now we are starting the session 2. Session 2 is from barriers to solutions, how to implement, how to open up the field and the horizon for more foot salvage and less problems, less and less amputations. The first speaker in session 2 is Dr. Abdelrazak Abdelaziz from Syria. Dr. Abdelrazak, are you here? Dr. Abdelaziz?
Okay. Do you hear me?
Yes, we hear you, Dr. Abdelaziz. You can share your
good
screen.
Evening to
Yes.
all. Now, okay.
Can you go for full screen, please?
Yes.
Okay. Okay.
Okay. My session will be, I will talk about the Syrian crisis and how we treat the diabetic foot patient. We will talk about the reality of diabetic foot in crisis area. Content, introduction, the reality of standard care, the reality of the healing time, the healing time cost, the reality of amputation goals and recommendations. Introduction. First, foot ulcers are defined as lesion involving a skin break with loss of epithelium. They can extend into the dermis and deeper layers, sometimes involving bone and muscles. Diabetic foot ulcer could be wound or chronic pressure ulcer. Diabetic foot patients are firstly at higher risk of neglect during the crisis in the absence of early detecting of wounds, deformities, and peripheral arteries disease. Diabetic foot ulcers likely come to the podiatrist in advanced stages and get into amputation. The unhealthy environment drives the diabetic foot ulcers towards injuries, cellulitis, and infections. Adopting standard care of diabetic foot patient could not be always affordable, especially in the crisis area. Performing training programs for health care workers, providing healthy environment to protect diabetic foot ulcers from injuries, fighting the infectious agents, and reducing the amputation rates would be hard a challenge in the third. The reality of standard care. Many of rural medical centers and mobile clinics are created by non-governmental organizations. However, a lack of advanced training for employees and volunteers in screening diabetic foot patients in early stage of foot problems caused an increase in amputation rates. Also, these centers and the clinics have a difficulty in following up patients for weeks, and that leads to fail in offering the standard care diabetic food. The kind of practice could explain why many resistant, advanced, and recurrent diabetic foot present in diabetic foot centers. The priority of non-governmental focused on the relief activities during the crisis time. They offered primary health service and fought against the epidemic. Governmental hospitals trained their staffs and equipped departments very well to receive disaster victims. However, that could lack in beds and instruments that usually were provided for illness people who need a long term of medical care. Example, diabetic foot patients. So the aggressive debridement or minor amputation were sometimes managed under regional anesthesia as outpatient. The patient is managed aggressive debridement and or minor amputation and follow up by scheduled appointments as outpatient. Low cost material and workable in such a crisis area. We used ethynyl phenyl acetate filtered foam technique, closed cell film, which was measured exactly to fit the plantar aspect of the foot, using a scalpel and aperture for cut from the foam at the exact location of the ulcer, allowing offloading.
Dr. Abdel Razak, time is over. We can have one more minute if you want to accelerate a bit.
The clinical trials from Syria could play an important role to clear the reality of how society during the disaster could face a big health issue like a diabetic foot ulcer. We reviewed the healing time of 1,747 neuropathic diabetic foot ulcer from the main diabetic foot clinic in Damascus. We predicted many variables that could prolong the healing time. The SIMBAD classification was performed to grade the severity. This table clear how the numbers and how we use the SIMBAD score. More or equal or more than 3 or less or equal or less 2. We noticed the presence of infection during the healing and the peripheral artery disease during the healing, with the presence of deformity during the healing time, location of the wound, if there is a plantar, make the daily healing time. The healing time cost, the difference in diabetic foot cost between the developed countries and low-income countries, especially in those suffer from disaster and the crisis, should be explained by many factors. First, the pay differences among healthcare workers between the two the categories of countries. Secondly, the developed countries usually use the cost advanced equipment more frequently in diagnosis, monitoring, supporting the diabetic foot management. Example, laboratories, MRI, nuclear bone scan, angiogram, vascular procedure, revascularization. Also, materials that use it in the tracing of loading and footwear are definitionally not the same in the two categories country. We here use the weekly cost and the mean cost. If the SIMBAD score more equal or more 3 was the 35 and 80, about 35 and $800. If the score equal or to 2, the cost was $375. If there is infected ulcer or non-infected ulcer, if there is infected ulcer, the cost was 4,000, about 5,000. Of a non-infected ulcer was $576. If there is peripheral artery disease, the cost was about $4,000. Without peripheral artery disease was about $2,000. If there is a plantar ulcer, the cost was about $33,000. Non-plantar ulcer, $2,200. Goals and
can we conclude,
Doctor? Yes. Now, yes. Goals and recommendation. Annual screening for diabetic foot patients, adopting the newest and simplest classifications that are used and supported the research papers, educational program, lecture, notebook, media for diabetic foot patients and for medical care providers for diabetic foot patients. The need of low cost and incredible diabetic shoes, electronic medical charts, and which are specified for diabetic foot patients. Non-governmental organization and local institutions that work in crisis area should pay attention for special care requirements of diabetic foot patients for the standard care of the diabetic foot and regular follow-up till the healing eventually. Thank you for your patience, my follower. Thank you, Dr. Jamil. Thank you to all.
Thank you. Thank you very much, Dr. Abdul Aziz from Syria. And now we will be talking about the role of podiatrist with Dr. William Aqiqi from Lebanon. William, are you there?
Yes, can you hear me?
Yes, I can hear you. And you can start sharing your screen. In the meanwhile, I want to say one word. William is a blessing in Lebanon because we have one real serious and professional podiatrist. He will be talking about barriers to podiatric care in the MENA region. Dr. Aqiqi, the floor is yours.
Thank you for your introduction, dear Jamil. Hi to all, and it's always a pleasure to see you. And we've been used to see each other physically, but now we're meeting virtually. At least we are meeting. So there's no doubt that we have so many barriers to treat the diabetic foot ulcers. There's no secret that we are one of the regions in the MENA having the most of diabetic population, and it will be almost doubling by 2045. What's the worst thing? The worst thing is that 45% of the people with diabetes in the MENA are undiagnosed. What is not a surprise also is that we have a very low number of podiatrists. We don't have an exact number because there's no local professional associations. There's no affiliations to the FIP. There's no regulations in the countries. So we don't have official numbers. So my number is based on, and generously, very generously based on what I know with the help of Dr. Khalid Idris. I'm saying that fortunately will be 70 podiatrists, but we don't have any official number. Maybe we are around 50 or 60, I don't know. So the barrier is the number, very low number of podiatrists. So in the MENA, we have one podiatrist for 6.64 million person, when it's compared to Europe, when we have one podiatrist to 21,000 person. So that means we have the highest number of diabetic people and the lowest number of podiatrists by person. What does it mean having low number of podiatrists? Is the absence of a proper care and the lack of awareness for professional health workers, or even for the population. When they have problem, they don't know where to go and they will not have access to the proper care. Other barriers are long distances. We are in countries, I'm not talking about Lebanon, but maybe like Saudi Arabia, Egypt, where there is very long distances to travel for patients when they are in the countryside, when they don't have access to care in their villages. So traveling long distances is very problematic for them. There is not proper transportation, and the proper ones are very costly. So when they have to travel also, they have to get accommodation. If they don't have enough money to get an hotel, they have to look to a sibling to have accommodation at their place. So we don't have enough podiatrists. We don't have enough infrastructure to get to the care. Other barriers are the non-availability of raw material to produce the orthotics. What type of orthotics? We don't care for now. We care about having anything to offload the diabetic patient. If it is a new generation of offloading, or it's a basic one, it's being problematic. There's no local production of raw materials. Everything should be imported. And then when we talk about imported material, we're talking about very elevated cost. The absence of trained technicians is also a big burden for podiatrists in the MENA region, for prescribers of orthotics. We have just people trying to do their best. We just saw Dr. Abdelrazak trying to do some offloading with what he had, but it's still not there regarding the quality of care. And as it is for Europe or even the States, the lack of reimbursement is also a burden. So if you permit, dear Jamil, so I can jump in a few seconds to how to overcome those barriers. So the first thing we have to think about is to provide training.
We still have.
How many minutes do I have? I need 2 minutes, and then we can discuss.
Yes, go on.
So the first thing is that we need training. We need training to get training in podiatry to get correct nail care. We have to train staff nurses or practical nurses. I think that if we don't have podiatrists, we have to train them. They will be the best guys to deal with the foot care. We have to train people to get the right offloading techniques, like having total contact cast or even orthotics. I think the cast technicians, they are really available on the spot when we need total contact cast in any hospital. So the cast technician can be present immediately to put on the cast. We also have to train people like cobblers, shoe technicians, or even shoemakers to manufacture properly the custom-made shoes or even insoles to get delivered to the patients. when we talk about training, we are talking about courses. So we should have, I think, custom courses for every country or group of country. When we have neighboring countries, they can get together to have a proper course. We can think about running floodbird programs. It was run already by the Food International, I think, in the Far East, and then the results were very good. And then we should have collaboration with the local authorities like the ministries of health, education, other NGOs or scientific committees. Other solutions that should be more sustainable, and then this will help us resolve this problem for long term, like the creation of podiatry schools on different levels of podiatry. We can have podiatrists, assistant in podiatry, or even technicians that will produce the proper orthotics. So those can be a very good sustainable solution to solve this problem on the long term. And we don't have to forget that we have to push to vote laws to regulate the podiatry profession and its allied specialties, because not everybody can do the offloading or do the care for the patient safety at first. Other quick fixes, Dr. Abdelrazak talked briefly about the mobile clinics. We can equip medical buses to go and to turn around the countries with periodic stops. So in the countryside, they will know that every last Tuesday of the month they have the bus coming to deal with the diabetic foot and then ensure the proper podiatry care. We have also to encourage, and it's really feasible and very quickly, the satellite centers. They should be managed or supported technically and financially by the centers of excellence in the big university medical centers. And we don't have to forget seeking regional collaboration. We have to collaborate with each other and the MENA region, and then we have to seek for the collaboration of big association like the Food International, the FIB, and other Wounds Canada, and other big association that can help in creating the best quality of care in our region. Thank you very much. Jamil?
And now I want to extend the apologies. Yes, are you hearing me?
Yes, I missed the connection for a second. I can hear you. Can you hear me?
Now, Dr. Hanan Gawish, are you ready? Dr. Hanan? Dr. Hanan? Dr. Hanan Gawish from Egypt are you ready? Dr. Hanan, if you are ready, please start sharing your slides. Dr. Hanan?
هلا بلشت تعمل هيك قطعت بركي الانترنت.
Hey, I am not connected. لا خلي هو بس يعمل لا ماني لا هذا سكرين تبعي. ايه بس ماني كونكتد. هو بيعمل اوتو كذا مرة راح واجا بس هلا راح بالمرة.
وين زوم انت وين بشو وين البلاتفورم زوم؟
دكتور جميل I don't think
نحن سامعينك نحن دكتور جميل ما في مشكلة عندك انت.
دكتور حنان مش موجودة زي ما الدكتور بيقول.
دكتور حنان is not here. Okay, so
Dr. Jamil, we are hearing you, but Dr. Hanan is absent, not in the screen. I don't notice it.
Okay. So for the sake of time, we can move. Ad, are you ready, please? Okay.
Thanks.
Adi, are you ready?
Yep, 1 second.
Please, Adi, if you can post the video from Dr. Safwat Hosseini. Dr. Safwat is originally from Egypt.
Okay, you ready?
Adi, go ahead.
Regarding to the diabetes, our percent almost 28% of population.
So now Adi from the team of Wounds Canada will give us the video of Dr. Safwat Al-Hussein.
Regarding to the percent, diabetic food, usually 20% of those patients get the problems. Almost also 18% of them get big complication for total amputation. 50% get ulceration. We have wound management clinic since 11 years. We have international Khurfankan conference for education, doctors, nurse, GP, and technician. We have hyperbaric chamber in our hospital, Qasim Hospital. I am leader of remote wound care for 17 hospital. So we have the skin substitute registered in all ministry of Image, Integra, Matriderm. Also, we have the most advanced technology in dressings, nanotechnology, Civitac, hydrofiber, and so on, Manuka honey, and so on. Plus, we have a regenerative center. Last 2 years we opened it, like bioprinting. The technology is very recent. From liposuction, you can take the photo of the wound and you can make it like puzzle. And we have growth factor registered, Cassiblique from France, and epidermal growth factor from Cuba. Yes, it is not registered, but we are using. So our rate is reduced. I hope we are sharing together for future to reduce and manage wound diabetic food. Thank you.
Thank you, Dr. Safwat. You are here with us following from the start of the webinar. You are a good friend and very active in UAE. And now we move to the second video from Dr. Larijani from Iran. Ms. Adi, can you post please the video of Dr. Larijani?
The global act against amputation,
and
the
after the
prevalence of
video, Dr.
amputation, and the
Larijani, we will
status
have
of
a group discussion about implementing strategies.
The food care. I would like to thank the organization of this meeting. The outline of my talk is about the burden and amputation, food care, and future strategy plan, and the conclusion. The burden of diabetic foot is very high, and the rate of the incidence annual of the amputation is 2 to 4%, and the cumulative incidence of diabetic foot was 5.6%. The burden of diabetic is high, and the complication of this is one of the problem of the health issue. The hospitalization, infection, foot amputation, decreased quality of life, and premature death is the complication of diabetic foot. There are many retrospective study and research study about the diabetic foot, and the wood side of the foot care, evaluation of the wood class, amputation site, and causes of the diabetic foot, osteomyelitis is one of the important issue. The multidisciplinary approach in diabetes care in Iran is a very important issue. The capacity building, practice of the patient, educational research and clinical infrastructure, and the clinical outpatient clinic, and especially the inpatient ward for diabetic management. Multidisciplinary approach is the foot clinic existing diabetes care facility for integration services, and this is, you can see in this slide, the Center for Outpatient Prevention, Management and Rehabilitation. The healthcare professional empowerment is very important issue, and we educated the nurses and GPs, and the several books for the diabetic foot guideline and virtual education for diabetic foot and diabetic academic website. And this is the diabetic foot education workshop for nurse group. And this is the empowerment of the education vocational training for the improved technical and educational skill of this group. And you can see in this slide the diabetic foot workshop organized by IDF and EWMA. And the diabetic foot guideline is important based of the guideline of the international group, developing national clinical pathway. It is very important with the support of the Ministry of Health. This is the ward of the diabetic foot. This is the special ward in the whole country. And the future strategy is national diabetic foot guideline and national pathway will be fully implemented in the all level of the clinic care. National Iranian diabetic foot registry system, new research project, national and regional demand based on this, and the multidisciplinary care of the diabetes expansion to whole of the country, and the assessment tool standardization of this issue, and the collection of the more data on the prevalence and clinical situation. In conclusion, the burden of diabetes is increasing in all of the country and in Iran. The diabetic foot is a global threat because of it continues to be a major cause of morbidity and mortality because the increasing rate of the diabetic mellitus in all of the world. The diabetic foot is the serious threat of the health of diabetic patient and maybe lead to dependency to the other. There are significant achievements in research, education, and clinical care, and the plan is the expansion, the design, and address the national
Okay, so I think it is now time for the group discussion. The theme of our second session was moving from barriers to new horizons and to more implementation. Are you hearing? Dr. Mariam Boutros, can you please take over and
Thank you. Thank you so much, Dr. Halaby, for chairing this meeting. So we're going to open it up for any questions because Dr. Halaby's connection is being challenged right now. Any questions that the audience may have for the speakers? If you have any questions, feel free to post them in the question. Salma, Dr. Kaburik, thank you. Please, you can speak at this point. Salma, you had a question? Do you have your hand raised up because of a question? Maybe we're having some technical difficulties. At this point, there doesn't seem to be any questions in the audience. I would like to thank DFOOT and Dr. Vijay's team for all the support that we have received. I'd like to thank Adi for supporting us in the technological background and all the wonderful speakers and the delegates that have really supported and informed this important meeting. So very grateful for all your contribution and extremely grateful that we all came together to increase the awareness about the prevention and management of diabetic foot. There's a lot of wealth within the region. And as we continue to work together as a knowledge network and a community of practice, we look forward to really being able to influence research, policy, and education in this area. So I really want to thank all of you for the great work that you have done and for your continued commitment to supporting the work in this space and improving the outcomes of your patients and supporting the work that is happening at a global level at DFOOT International. Thank you so much for everything and all your contribution.